الله الرحمن الرحيم. أنا الدكتور عبد الحميد البهنسي، رئيس قسم المسالك البولية، كلية الطب جامعة طنطا. أتكلم معاكم النهاردة إن شاء الله تعالى على genitourinary trauma upper and lower, and mainly the most important trauma is the trauma affecting the kidney, ureter, and the bladder. Generally, the urinary trauma is not always obvious. That's why we need detailed history about the trauma, the mechanism of the trauma, and we need also meticulous clinical examination, as well as we may need laboratory and radiographic study to diagnose the trauma. And each patient has to be assessed and treated separately. First, we'll talk about renal trauma. The aim is for successful management of such very specific trauma, and for this successful management to begin with accurate injury detection and classification, which means determination of the extent of the trauma, which is staging. Staging to determine the extent of injury, either clinical, radiographic, or even during surgical exploration. Accuracy staging will aid in selecting which patient needs surgery and which patient will be treated conservatively without intervention. In this chart, we'll find out that after clinical evaluation, we will have one of two types of trauma mainly, either blunt trauma or penetrating trauma. And once we know that the patient had penetrating trauma, definitely we will ask for radiographic staging of such patient. On the other hand, if the patient underwent a blunt trauma or had some sort of blunt trauma, we may ask for urine analysis if the patient is stable. And if the urine analysis shows gross or microscopic hematuria, or if our patient is in shock after recovery from shock, or clinical indication for any other problem like trauma within other organs in the abdomen, or if our patient is a child less than 16 years, in this condition also, we will have to do some radiographic staging. Renal trauma is classified either by the mechanism, which actually an indication for the etiology, into blunt trauma, penetrating trauma, or iatrogenic trauma, which is done during surgery. Some examples in this slide for the blunt trauma. Blunt trauma constitute about 90% of renal injury, like direct blow, laceration from traumatized lower limb or fractured lower limb, or fracture as a transverse process of lumbar vertebrae between 1 and 3, and the main vessels may also be injured by blunt trauma, like deceleration injury. Penetrating trauma in the form of stab wound or gunshot, and examples for iatrogenic trauma are extracorporeal shockwave lithotripsy or percutaneous nephrolysis. Another type of classification which is clinically accepted is to divide the renal trauma into minor or major. And minor trauma in a form of contusion, minor laceration, or small perirenal or subcapsular hematoma. Major renal trauma in a form of major laceration through the whole thickness of the renal parenchyma, up to the corticomedullary junction, and even penetrating into the collecting system, or vascular injury, including segmental artery thrombosis, main artery thrombosis from direct blow or intimal tear, or even main artery and or vein avulsion. In fact, it's usually a complex, which means you may find some minor trauma in the kidney and in the same kidney in another area, another major renal trauma. For scientific use, the American Society of Trauma has classified the kidney trauma into 5 grades, as we will see, and it ranges from grade 1, which is the simplest or minor trauma, to grade 5 in a form of even shattered kidney into multiple pieces with a huge hematoma. In this scheme, you will see the different grades or examples drawing for different grades, starting from the upper left side, grade 1, small hematoma, grade 2, small laceration through the renal parenchyma, less than 1 centimeter, grade 3, large laceration, more than 1 centimeter but not reaching the corticomedullary or the collecting system, doesn't reach the collecting system. Grade 4, lower left side, this grade has larger than 1 centimeter laceration with or without affection of a small renal vessels, and it reaches the collecting system. And lastly, grade 5, you will see that the kidney changed into multiple pieces, or the main vessels has been injured severely. During trauma, the condition is urgent, and we need to select rapidly our radiographic study to choose one study that help us and help even to detect any trauma all over the system or all over the abdomen. That's why we have to coordinate with the trauma team. If there is another trauma in other system, and one study can show all systems, I mean liver, spleen, bowel, and urinary tract, we agree with them and we will choose this kind of radiographic study that help us and help us to show the other system. Today, we know that IVU doesn't define adequately the renal injury, but on the other hand, CT with contrast, if the patient is stable, can be done, and it's available everywhere, especially in the university hospitals. Accurate staging and determination of the extent of the injury is the main purpose for any radiographic study for a patient who had any type of renal trauma. Imaging study in the past, we used intravenous urography with double dose. Even inside the theater, we can put the contrast material in the saline or glucose intravenously and ask for intraoperative X-ray film. This gives us some sort of information about the affected kidney and the other kidney. In some cases, we may need arteriography to determine if there is some sort of segmental or vascular renal injury. This is an example for eye view. You can notice clearly that the right side of the patient, right kidney and right ureter, looks perfect. On the other side, the left side, you see contrast material outside coming from the lower calyx and extravasated outside the kidney. This is a case of a stab wound in the lower pool of the left kidney. Again, ultrasound is not that perfect in detecting renal trauma, while CT is considered to be the best single imaging study in such a situation. It's sensitive to find out and detect any kind or degree of extravasation. It's also beneficial in detecting any associated organ injury. Again, renal artery thrombosis can be reliably identified when we use a contrast during CT examination. We know that it's widely available in most of our large hospitals. In this slide, you can see a comparison between ultrasound and CT. Ultrasound on the left side hand of the slide, while it's for the same patient, CT with contrast on the right side hand, and it shows how clear CT is helpful. That's why it's said that properly performed CT scan will tell everything for the doctor he needs to know about the kidney radiographically. In the recent era, MRI and renal trauma, magnetic resonant imaging scan were accurate in finding pre-renal collection, assessing the viability of renal fragments, and detecting pre-existence renal abnormalities, but failed to visualize any urinary extravas on initial examination. You may need more than magnetic resonant imaging studies for the same patient to detect if there is extravasation in reality. Again, in the coming slides, we will show how does it look like the different grades of renal trauma. This is a diagram on the left side for grade 1 renal trauma in the form of contusion. And how does it look like in a CT with contrast, computed tomography with contrast. This is an example for grade 2 with minor laceration of the renal parenchyma less than 1 centimeter. Another case with grade 3 on the right sided hand X-ray, and it shows a laceration with extravasation around the kidney. 1 centimeter doesn't reach the collecting system. This is a larger laceration on the left side hand of the patient, and we can see that the hematoma is large around the kidney, and the laceration almost reach the collecting system. Grade 5, which called shattered kidney. You see piece of the kidney with contrast far from the rest of the kidney, so it's almost completely separated from the kidney with a huge hematoma around the kidney parenchyma and even crossing the middle. How should we manage the renal injury or kidney trauma? Successful management is based accurately on determining the extent of the injury or the renal trauma staging. Staging can be done clinically, radiographically, or even surgically during exploration. Some patients may require only clinical staging, and if they are stable and the urinary tract seems okay and the urine output is fine, we put them on watchful waiting. While other patients, especially children, patients who lost a lot of blood, or even patient with any trauma to other related organs like liver or spleen may need the whole three different staging procedure: clinical, radiographic, and surgical staging. Practically, renal injury are considered either blunt or penetrating. As regard blunt trauma, for general guidelines, we start with clinical staging to determine, do we need radiographic staging? Do we need to do some radiological study to confirm or find out the real stage of renal trauma? And clinical and radiographic staging will tell the doctor or tell the urologist, do we need surgery or not? Overall, minor trauma or minor renal injury are safely and properly managed by watchful waiting, putting the patient under observation for 24 or 48 hours will be enough. Most renal injury are caused by blunt trauma, as we said before, around 80 to 90% of cases, while 2 to 3% only of such cases will. If we have a case with blunt trauma with major laceration, how should we manage? This is a controversial. Some will prefer will prefer to manage by conservative treatment, putting the patient under observation, giving antibiotic, replace the loss as regard to blood, and support the patient with fluid and putting him under close observation. But if we have a complete transected or shattered kidney, which is lucky enough are rare, we can do surgery at this situation, putting in mind that saving the patient life is more important than saving the kidney. As regards the penetrating injury, most of the penetrating injury require some kind of surgical intervention, and in such cases, laparotomy is usually required not only to repair the kidney but also to take care of other organs. In this slide, we will count some of the absolute indication for surgical intervention and other relative indication for such intervention. The absolute indication include renal bleeding with hemodynamic instability, expanding or pulsatile retroperitoneal hematoma during laparotomy for any other reason, or proven main artery injury, especially if it's bilateral or in a solitary kidney. The relative indication for surgical intervention include non-viable tissue and major laceration, urinary extravasation, which is significant, renal artery thrombosis, incomplete injury staging in a special type of patients, or if we have a patient who have to undergo laparotomy for concomitant or associated injuries elsewhere in the abdomen. Now, talking about the ureter and urethral As you all know, ureter is not just a tube, it's a physiological conductive system between the renal pelvis to the urinary bladder, and it consists anatomically from different layers. Lucky enough that urethral trauma is infrequent and constitute less than 1% as an isolated injury in the urinary tract. Ureter is protected, as you know, by the back muscles. That's why it's a little bit very rare to have isolated urethral trauma. Urethral injury may be partial or complete, may be caused also by blunt or penetrating trauma. However, iatrogenic injury are the most common cause for urethral trauma during endoscopic procedure or open surgical procedures. It is characterized by delaying diagnosis because ureter is very far from to be noticed. I'm talking here about the isolated urethral injury. Iatrogenic trauma is considered the most common cause of urethral injury, and it can be done by open surgery, laparoscopy, and or endoscopic procedure to take care of some problems within the ureter. The mechanism during open surgery and or laparoscopy include crushing from misapplication of a clamp, ligation with suture, transection with a scissor, angulation during dissection, or ischemia from urethral stripping, or use of excessive electrocoagulation during any surgical procedure, resection of part of urethral segment unintentionally, or any of these causes in combination. Iatrogenic trauma of the ureter constitute more than three-quarters by gynecological procedures, while the injury usually affect the lower third of the ureter within the pelvis. How can we detect urethral injury? By high index of suspicion, taking a detailed history, knowing what happened during the last few days for this patient underwent surgery, any type of surgery close to the ureter, or finding any type of hematuria, microscopic hematuria or macroscopic hematuria, knowing about having any kind of penetrating injury to the common iliac vessel or the bladder. In such cases, during exploration, we have to find out if there is any urethral injury. In two-thirds of the cases with isolated urethral injury, the diagnosis, as we said before, is delayed for few days or even weeks until it show up with. As regard the radiographic studies that is needed to determine if there is any kind of urethral trauma, recently spiral CT with contrast is a very helpful, especially if we talk delayed films. This is mandatory in such cases. In the past, IVU was the standard tool for the evaluation before the widespread use of CT scan with contrast. As the most accurate procedure for diagnosis of urethral injury, retrograde ureterography using endoscopy, inserting a ureteric catheter by the endoscope in the lower part of the ureter and having a ureterography or a ureterogram by injecting contrast to delineate the ureter This is was the most delicate diagnostic test, but in acute cases, it's not, of course, practical. Using any radiographic study for diagnosis of urethral injury, the diagnostic sign is the presence of extravasation. Again, urethral trauma can be classified into 5 grades, as we see in this slide. Grade 1 is the simplest and the least type of trauma, and it forms of hematoma around the ureter. Grade 2 laceration for less or 50% of the circumference of the ureter. Grade 3, more than 50% of the urethral circumference is lacerated. Grade 4, complete tear less or equal to centimeters of devascularization. And lastly, grade 5, if we have large tear losing about more than 2 centimeters of devascularized urethral wall. This is an example. How does it look like losing part of the ureter? In this MRI study, delayed diagnosis of an injury for the ureter more than 2 centimeters in length, as is shown in this slide. How should we manage a case with urethral trauma? If we have acute trauma and you can make immediate diagnosis, immediate repair is the best way to deal with. But if we have a delayed diagnosis, by discovered, I mean, less than 5 days, we can think about exploration and repair. But if it's diagnosed after the 5th day from the trauma, or diagnosed in a debilitated patient is sick, so sick to undergo surgery at that time, all what we should do is to control urine leakage with a stent or diversion, proximal diversion, and draining the urinoma. At that time, then we will schedule our patient for repair later on. What are the most common complications after urethral injury? Is urethral stricture, recurrent urinary tract infection, or other complication related to the presence of a lot of urine outside the urinary tract, which we call it extravasation or urinoma. Last part of our lecture will talk about the urinary bladder trauma. Trauma to the urinary bladder usually result in most cases from motor vehicle trauma. 8% from fall from height and 2% from crash injury. Less than 1% from penetrating injury, and half of the cases during surgery, which we call it iatrogenic trauma. Again, grading or staging is very, very important to determine how should we manage the case. Bladder trauma can be one of 5 grades. Grade 1, just a contusion with intramural hematoma within the bladder wall, and this is usually discovered on X-ray. Or partial thickness of the bladder is injured. This is also is considered grade 1, but no extravas. Grade 2, this means the presence of extraperitoneal bladder wall laceration less than 2 centimeters. Extraperitoneal and less than 2 centimeters. But if we have extraperitoneal trauma to the urinary bladder and larger than 2 centimeters, we are talking here about grade 3. So grade 3 is considered when we have larger than 2 centimeter laceration of the bladder wall extraperitoneally, or intraperitoneal laceration, which means the bladder content goes into the peritoneal cavity, but the laceration is less than 2 centimeters. Grade 4, and this describes an intraperitoneal bladder wall laceration between 2 and 4 centimeters. Lastly, grade 5 trauma of the urinary bladder include intraperitoneal or extraperitoneal bladder wall laceration extend to the bladder neck or the urethral orifice. And this is the most important part of the bladder trauma, grade 5 trauma. Now we will show some of these grades. How does it look like? This is a picture for grade 1 trauma to the to the bladder wall. As we see here, a small collection within the bladder wall. Grade 2, a small laceration less than 2 centimeter extraperitoneal. The cover above the diagram is considered to be the peritoneum. Grade 3, large laceration in the bladder wall, but still extraperitoneal and does not extend to the ureter or the bladder neck. Another example for grade 3 is small, less than 2 centimeter laceration, but here the extravas extend to intraperitoneally. Grade 4, large laceration and intraperitoneal leakage. This is considered the grade 4 bladder trauma. The most important and the most sensitive is the grade 5. If the trauma affects the bladder neck, as we see here, very close affection of the bladder neck together with large laceration of the urinary bladder wall. How can we diagnose bladder injury? Of course, from the history and determination of the type of trauma, the presence of gross hematuria, which is common, and the abdominal tenderness, especially at the suprapubic area. Again, inability to void the presence of any bruise on the suprapubic region is a great suspicion for bladder trauma. And lastly, extravasation of urine may result in swelling in the perineum, in the scrotum, in the thigh. If we have any kind of extravasation in this area, as well as in the anterior lower part of the anterior abdominal wall, we are facing a case most probably of a bladder trauma. How should we evaluate? The major step here is to find whether the injury is intraperitoneally or extraperitoneal, large or small, and its relation to the bladder neck. We need, in such a case, to have a plain film on the pelvis, on the bones, to find out how does a pelvic bone look like, normal or fragmented or large fracture in the renal pelvis. Ultrasound in such a situation tell you something. There is extravasation, but doesn't give you any data about the extent of the bladder trauma. Again, intravenous urography is not useful in bladder trauma. This is a sphere that should be filled with some sort of contrast to find out the extent of any injury within the bladder. During computed tomography with contrast, cystogram part of this study may be sensitive, especially if there is large amount of fat around the bladder or significant extravasation, and we will see examples. The most important and most diagnostic key radiological study in case with bladder trauma is what call it trauma cystogram. A catheter is placed in the urinary bladder by a urologist, and the bladder is filled to 30 or 40 centimeter water with contrast, and we will ask the radiologist to give us multiple projections, which means in different sides, posterior anterior film, lateral film, oblique film, to find out the degree and extent of any extravasation. And at the end, we should drain whatever inside the bladder by draining, opening the catheter and have a drainage film. Again, we may use fluoroscopy and show this in life. Show how does the bladder fill and how does the bladder empty and in between. In case with intraperitoneal injury, contrasts into the peritoneal cavity, often outlying loops of bowel or at the lateral gutter of the abdomen. While extraperitoneal injury, the contrast will be shown streams in the perivesical tissue or fat only. This is the case as we see in this cystogram, trauma cystogram, that we have extravas on the left side hand of the patient, still extraperitoneal. And this, how does it look like having intraperitoneal contrast material due to intraperitoneal bladder rupture or bladder trauma. Again, CT with contrast. On the right side hand of the bladder, we can see some extravas within the fat around the urinary bladder. Do we need some sort of endoscopy or instrumental diagnosis for bladder trauma? We may need, in some cases, to do cystoscopy. Cystoscopy is very sensitive and indicated in a stable patient. It shows the degree and the extent of the bladder injury, the site, and it makes help to make decision whether such patient will need intervention or not. How should we treat bladder trauma? In general, extraperitoneal small trauma is considered a case for watchful waiting, putting a catheter, taking care not to have infection, replace any blood or fluid loss in such patient, and that's it, except if we have a massive hematuria or suspicion for having bladder neck injury, because this in the future will have very important complications if not managed properly. On the other hand, intraperitoneal bladder rupture or bladder trauma. Sometimes, if it's small and self-limited, the patient is stable, can be treated the same as extraperitoneal trauma by having a good size bladder catheter, put in drainage, giving antibiotic, watchful waiting. If there is a small or no herniation of bowel or omentum into the bladder, again can be treated with a catheter. Cystoscope in such a case is very important to determine do we need intervention or not. In most centers, they prefer to treat the intraperitoneal bladder trauma with placement of suprapubic catheter. We will have suprapubic catheter with or without urethral catheter. So we may need some sort of intervention. This catheter should be placed by open surgery. If we do so, in most of the cases, we can take care of the trauma by palpating the site, feeling the site of the trauma through the urinary bladder and closing it during the surgery. If any bladder neck injury found, we have to repair such type of bladder. Thank you and good luck.